Welcome to Talk Dizzy to Me, the show that brings you a comprehensive look into the complex field of dizziness. Now, here are your hosts, vestibular physical therapist Dr. Abbie Ross and Dr. Danielle Tate.
Welcome back, everyone, to Talk Dizzy to Me. My name is Dr. Abbie Ross, physical therapist, vestibular physical therapist, and neuroclinical specialist, and I'm joined by Dr. Dani Tate, also a vestibular physical therapist. Today, we have someone that we've recommended to many patients, and many patients have come back to us singing their praises. So everyone, welcome to the show, Dr. Shin Beh out of Texas.
Thank you for having me.
The new migraine guru.
Yes, the migraine guru. So
migraine only.
One of the first questions I always like to ask our guests who are clinicians in this field is, what brought you to the vestibular world? And give us a little bit of background in how you got to where you are.
Sure. So I've always found vertigo, dizziness, and eye movements to be quite fascinating, since medical school. It's like this one of those weird things you look at, you're like, there's something very, interesting about this. It's fascinating, and how you can localize it so beautifully. If you see a particular type of nystagmus, it indicates something. If you see something, with the eye movements that can localize to a part of the brainstem, the periphery. And so that was always very fascinating to me. And I think, it's also slightly perverse in a way because, I noticed that a lot of people fled from dizzy patients. They didn't want to deal with dizzy patients, didn't want to deal with vertigo, couldn't wait to, ship them off to a different specialist. So that kind of drew me in. I never realized that, it could be a specialty in itself when I was in med school. And then, as a resident, I found it very actually rewarding in a way to see the dizzy patients, especially, those with BPPV. When you get called down in the ER in the middle of the night and, somebody has BPPV and they're freaking out, they're not sure what's going on. And then you explain it to them, you treat it, they go home, it's great. It's very rewarding when you actually can, make something better. And then later in residency, I came to realize that, hey, there is a specialty within neurology. Some call it otoneurology, some call it neuro-otology, tomato, tomato. Same thing to me, right? But it's the, subspecialty of neurology that deals with vertigo and dizziness. And so, I decided to explore it further, read up Dr. Z's book, that wonderful book, about eye movements, wanted to rotate with Dr. Z at Johns Hopkins. My mentor at that time was Elliot Froman, who was one of the big names in multiple sclerosis. But little did anyone know that actually his fellowship was in dizziness and vertigo with Dr. Z initially. And later on, he went into multiple sclerosis. So I asked him, if we could, how would I go about going to doing a fellowship in vertigo and dizziness? And so he proposed something very interesting. He said, how about we do a 3-center fellowship? So, do a little bit of multiple sclerosis in Dallas, go to Hopkins, some dizziness, and then go up to New York and do some multiple sclerosis, neuro-ophthalmology, mixture of the two. He was collaborating at that time with Dr. Peter Calabrese at Hopkins and with Dr. Baltzer in Penn. And then Dr. Baltzer and Dr. Galetta moved to NYU. So it was the 3 centers. So I was like, hey, I had no commitments in Texas at that time, owned nothing except a little car. So I was like, let's do it. So, began that little journey. So 8 months I spent in Dallas, and then after that 8 months in Baltimore and 8 months in New York. It was fantastic. When I came back to Dallas, I thought, my specialty is just going to be, mainly multiple sclerosis and, do some dizziness on the side. Because I thought, what? There probably aren't that many patients, with dizziness. Little did I know. And then, and later, as I went through, my career, I was like, oh my goodness, there is a huge demand for people, with specialty in vertigo and dizziness. And whereas, there were quite a few other MS experts out there. So, I left MS behind, focused on dizziness and vertigo, and here I am.
That's amazing. Even just the residencies that you had lined up is like kind of like a dream come true to have a little bit of a hand in all of those and with such great people too. That's really, really cool.
Dr. Z is amazing. I learn something new every time I talk to him.
I can only imagine.
Those are the best type of mentors. Was it Dr. Z who used the quote? I saw this on I don't know if it was your website or somewhere I read that one of your mentors had said it's not about being right, it's about getting it right. Was that Dr. Z?
No, that's Dr. Froman actually.
Oh, different.
Yeah. That makes a lot of sense. Yeah, especially for dizziness, for vertigo, a lot of times, we have to really get it right. If we don't get it right, we can't treat them.
Good point. That's so true in this field, especially, you had mentioned that sometimes you can really localize what it is, but I'm sure a lot of patients that come to you, well, actually, I know because the ones I have sent to you have been to many people already, many healthcare providers already. So when a patient comes to you, they've seen 5+ healthcare providers. How are you dissecting their history to really localize or confirm or confirm what it is and what it isn't so that you know what path to take them on intervention-wise?
I always try to approach it from a very neutral standpoint. I try not to be biased by previous diagnoses. So, when I ask the patient, take their history, I try my best to come in from, an angle where, as if I don't know anything. And I want them to tell me about their history right from the beginning. And that way, I'm more confident in the diagnosis towards the end of the visit, rather than taking a diagnosis that somebody else gave or the patients, a lot of times the patients are right. Sometimes they read up and then they believe that they have a particular diagnosis and want to ask me about it. So rather than try to fit the symptoms into a particular diagnosis, I like to go through their history, get all the symptoms first, and then, come up with a diagnosis from there.
I like that approach. And that's very similar to, I think, what we take as physical therapists, because by the time somebody comes and see us, it's been recommended as almost like a last resort. And
Absolutely.
They've been through multiple people and every doctor just ends up saying, why don't you just try PT, try vestibular therapy, let me know how it goes. And at that point, we kind of have to take everything that they have to say with their history and their diagnoses, kind of put it aside for a second, do our own evaluation to see how the patient's feeling that day in that moment with their symptoms, and then kind of make a clinical judgment from there. A lot of the times it's not a matter of what the diagnosis is, but just finding the area of dysfunction to help treat. But then also educate the patient about that multidisciplinary approach. I have to say too, you had mentioned that not a lot of people like to treat dizzy, but there are a very, very few amount of people who like to treat dizzy migraine patients, I will say. So you've got a very small specialty in itself, but it's amazing. And we need more people like you because, like you said, this is a big, big common issue. And it's actually getting to the point where the diagnosis of vestibular migraine is starting to out-track BPPV for lead diagnosis of dizziness. They're finding that a lot of people have been misdiagnosed over the years. And now that we've got better diagnostic criteria, we're able to identify them a little bit better. And I kind of want to ask too, how has your practice changed since the beginning of this pandemic and the lifting of some of these rules on telehealth and telemedicine?
Yep. So we did some telemedicine before that in small numbers, some out-of-state patients, Texas is a big state. So, a lot of people live really far from Dallas. And so, we kind of dabbled in telemedicine before that, but not in, a big scale, partly because, insurance reimbursement was, not very good. And a lot of insurance companies wouldn't, even think about, tele. I think the pandemic did force telemedicine to the forefront and, really made it into an important issue and an important way to deliver care. Initially, of course, there is that discomfort. There is if you don't examine a patient, how can you really come up with a real diagnosis? But then, if you think about it, most of our dizzy patients, it's history. Everything is in the history. If you most of 90% of the time, I think by the time you're done with the history, you kind of know what's going on. And then you do the exam, and then, just to support what you find and, make sure that there's no other issues going on. 10% of the time you get surprised. You examine them, you find some weird nystagmus or something strange on the exam. You're like, oh, maybe there's something else going on as well, right? But I think those patients, after you take a good history, but most of the patients who have come to see me have had VNGs done, MRIs, VNGs, audiograms done. And so, that also takes a lot of away from the need to see the patient in person. Now if they had some findings in the VNG that was abnormal, let's say if they found like downbeat nystagmus, for example, and then the suspicion of a cerebellar issue comes up, then those I try to schedule them as an inpatient. So initially everything was tele, and then as we kind of got used to the pandemic, we were like, okay, as long as we wear masks, we had like a little half day per week where we come in person. And so those patients that I felt, there's something else that could be going on, I insisted, come in person, see me in person, do an exam, and then, figure things out from there. There have been a few that I've had to bring in, not many, thank God for that. But there have been a few, usually the cerebellar ataxia patients that we have had to bring in and say, I need to examine you. We need to get a few more labs just to make sure, see what's going on with the cerebellum. But, going forward, I think telemedicine, they will keep paying for it, the insurance companies, but I think it's here to stay. What I find more interesting, which you two can, Chip, tell me a little bit about, is I've heard of vestibular therapy being done by telemedicine now.
Yes, actually, it's funny you say that because we were participating in telehealth pre-pandemic as well. And the main reason was for access to care. So, you have a small, in the grand scheme of things, a small number of clinicians who specialize in this type of care. So if you're not in a main hub, chances that you're seeing a true vestibular focused provider is slim to none, right?
Yep.
So we did it so that we could reach those clients. And I've told this story before on our podcast, but when I was working at NYU, and actually I had some of Dr. Balser's and some of Dr. Aglada's patients before. But when I was working there, we were having patients come from all over. And I thought to myself, how crazy is this that people with vertigo are getting on planes, getting on subways, getting in taxis, and coming to see us? This is crazy. So when I moved to Florida, I decided to kind of venture a different way and see if I could help people virtually. I first did it with a friend of a friend, basically pro bono, kind of trial and error, and it worked beautifully. So then we expanded it. But like you already said, so much of it is in the history, and it's the same for vestibular rehab. When you see a patient, I could spend an hour on the history if I wanted to, unless it's something very straightforward. I am asking more questions and more questions and more questions and diving a little deeper until I kind of pinpoint what I think is causing it and then determining what path of treatment I need to take. But the other part of vestibular rehab that works so beautifully with telehealth is that so much of vestibular rehab actually relies on the home program.
Yep.
So why not start this program in the patient's home? They have to be safe to do what I'm asking them to do anyway. The only difference would be that I might take a few more steps in between. I might not go as challenging as I would in the clinic on some of the exercises. I might, space it out a little bit, make sure they're comfortable and safe to do something on their own before I push them a little bit further. But it's really the same as in-person care.
I will say, I'll just jump in real quick, Abbie. I was just going to say that in the beginning, when I first met Abbie, I was in complete disbelief. I thought she was crazy.
I get that a lot, Dr. Beh. I'm crazy.
I was like, you have to put your hands on a patient in order to really get a full comprehensive evaluation as to what's going on. But, even to something that you alluded to, a lot of patients come to us with testing done already. Yep. And history is everything. And it also actually kind of shaped my evaluation a little bit differently in the clinic, because even with the pandemic, I think it reinforced having to see patients over telehealth and telemedicine, that I don't need to do every test under the sun. we get a great history. We can do a couple of things to reinforce what is going on. And then it all comes down to the consistency of the home program. So it's been really interesting to see how this has kind of done a really great shift in care for our patients, but also for access. And I am so happy that we have more access to people like you to kind of send patients, and even especially for vestibular migraine patients, by the time we start to see them on telehealth and telemedicine, we have a really good idea once they start talking of what's going on. We don't have to do much to trigger those symptoms and start to set them on the path of finding the right multidisciplinary approach. So it's been interesting. It's been a really good mix, I think, of in clinic and out of clinic with telemedicine. And Abbie's, saw this way ahead in the future. She got her business started in 2019. So she was ahead of the bar on that one.
Yeah. Thank you both. But along these lines, Dr. Beh, medication prescription is out of our scope of practice as vestibular therapists. How does that work for you if a client or patient is out of state? Can you still prescribe medication? You can.
So we can. Non-controlled substances, we can. Controlled substances, the DEA doesn't approve of that. So you can prescribe that across state lines. Therapy is a little bit tricky. If I want to prescribe like physical therapy, vestibular therapy to somebody out of state, that's tricky because I think like with Medicare rules, you have to specify like the exact place and everything. So it becomes tricky with that one. Ordering tests can also be a little bit, tricky there. They need the order and they need to bring it to somewhere. But, with electronic prescribing medication, non-controlled medications, it's actually quite easy to do. They have the pharmacy can receive electronic prescriptions. It works quite well.
That's great.
I do want to say with medication, we've had comments in our past episodes that people are really grateful we talk about medication, because I think there's some stigma around people trying to avoid medication or want to stay off medication. But for some people, that is the missing link for their symptoms, is to get them on the right medication and the right type and dosage and whatnot. Would you say that you have a specific approach to medication when it comes to patients? Do you have like a kind of like a decision tree that you follow when it comes to trying medications, or it's all dependent on patient to patient?
Correct. I think it depends on the patient. So, I don't like to follow like algorithms. I say you have to start with this, I'm going to go to this and this and this, because, I think everyone is different and everyone responds to medications differently, right? I always tell patients, there's no way I can predict which one would work for you. There's no way I can predict which one would cause side effects, right? So I think that to try and I do it based on, what they prefer, their response to previous medications. And of course, any comorbid issues going on, because for example, if you say you have to start off with a medication like amitriptyline, for example, right? Now that one causes, drowsiness. It's great if you have insomnia, but if you don't have insomnia and then you're worried about, the hangover effect the next day, may not be such a good idea. And then there's, of course, the risk of weight gain with amitriptyline. A lot of people, the moment I mention weight gain, they go, nope, don't even talk about it anymore. Or, and then, if they have constipation or trouble with urination, then the medications like amitriptyline, nortriptyline could make that work. Propranolol is another one that's commonly used for migraine, but, if they're already running kind of low heart rate, blood pressures on the low side, may not be such a good idea. Or if they're really like active younger patients, you put them on propranolol, then their exercise tolerance goes way down. Topamax, a lot of people like Topamax. A lot of people hate Topamax. It causes the weight loss. Some people love that. But it can cause a lot of, cognitive issues. There's a tiny risk of kidney stones. So if they already have kidney problems, history of kidney stones, probably not a good idea to put them on Topamax. So I think it has to be individualized. I do have patients too who just want to try the supplement. I think that's fine. Give it a try. But now I always tell our patients, say, anything that you try, whether it's medications, supplements, dietary changes, it takes about 2 months before you can see some benefit usually. So, whatever you do, got to be patient with it.
I was just about to ask you that. You nailed it, though. So many patients, because we see the patients more often than typically the physician does. They say, I've been on this for a week and I feel X, Y, Z. I hate it. And I'm always saying to them, you're not going to know if you start, stop. It's really a trial and error. And unfortunately, you've got to go through the battlegrounds to see what works and what doesn't work. So 2 months is about your range to determine when they should come back to you and say, oh, I really like this, or this isn't working out.
Yep. Exactly. So 2 months for efficacy. But if it's, of course, like some bad side effect, then, we have to stop it sooner, right? If it's just a mild side effect, I try to tell my patients, try to tough it out a little bit, power through, put up with it. Usually that gets better. If you feel like, just a little funny on it, just feel off, put up with it, try to power through. But if it's something really bad, like say, you can't wake up in the morning, you're crawling, to the bathroom in the morning, then we'll try you on something else.
Yeah, the dizzy cook, of course, we've spoken to her on our episodes prior, Alicia Wolf.
Yep.
And we were talking about how important it is to have that relationship with your physician. You're more like a team. It's your feedback is so important in determining, or in the physician determining what path to go down. Do you stay on this medication? Do you try another one? Do you just try supplements? Do you get off medication altogether? Your feedback as a patient is so, so important. So I thought that was a really good point that the dizzy cook made.
Absolutely. And I tell my patients the same thing. I will adjust the medication based on what you tell me. Is this dose doing it for you? Is there still a bit of dizziness left? Do we need to go up on the dose? Are you happy at this dose? Side effects, do we need to go down a little bit? It depends. All of it is on feedback. And dizziness is so subjective. So we need that feedback.
Well, I liked everything that you just said when we started talking about medications. It kind of hits it on the head that everybody's different. Yep. Just because what worked for one person doesn't work for another, and everybody should be individualized. So even those of you who are listening that has gone to a doctor and say, well, I start all my patients on this, you might want to reconsider, your approach and relationship with that doctor to kind of find maybe a better fit. You want to find something that works for you. Your comorbidities is going to be different for everybody. And there are, if we haven't mentioned this in this episode, but previous, your book, Victory Over Migraine, you mentioned a lot of different things that actually I had questions about before purchasing your book, like using the Cephaly and other types of approaches and devices out there for patients that are suffering from migraine. Is there any one particular device or thing that you like that you've noticed has helped patients, or is it, again, different from person to person?
I think it's different. And the other thing to consider, we forgot to talk about is cost. Cost is a big one. The devices can work. The main thing is, I think with Cephaly, I've used it more because it's more accessible, right? I would have wanted to use gammaCore more, but then, the insurance issues around gammaCore made it very difficult to prescribe. Now it's easier. They have I don't know whether I can talk about it. Let's talk about it, okay? Right? So they have the new pilot program where, the cost is much lower, right? It's still, there's a monthly cost, but it's much, much lower. And, it's far more accessible now. So I've been, using it more with my patients. In the past week, it was just too difficult to use. So, I'm waiting to hear back on the gammaCore. It can potentially work. There was that study in Europe that did triple PD patients, and it showed that over 2 months, the gammaCore did help. The Cephaly, I'm finding that it does help too. Not everyone, but that's everything, right? There's nothing that works 100%. So Cephaly can work. The gammaCore can work. The one that I'm, very interested in this year is, I think it's called a Relivion. So it does trigeminal and occipital stimulation at the same time.
Oh,
so,
interesting.
Yep. Exactly. Depending on, what they come up with, whether it's going to be like a rescue treatment or whether it's a preventive treatment, whether they'll just let you, do whatever you want with the device, we'll see how it goes, right? It could be something quite interesting, especially, a lot of our dizzy patients have neck pain. Yep. So it could be quite a useful.
Yeah, absolutely. And there are other approaches too, as far as Botox and CGRP injections and things along those lines. Like, it feels like that there are a million things out there that people can tap into. And part of the trickiness of treating migraine, especially vestibular migraine, is finding what works, just because it almost is like a rabbit hole of so many different things.
Correct. Yep. It's good on one hand that, we have so many choices now. the thing is, to tell our patients too, there's no magic bullet, right? A lot of them say, okay, what is the one that works the best? There is none that works the best. Unfortunately, all of them can work. If not, I wouldn't offer them to you. But there isn't one that works, the best of the lot from what I've seen. There's some that work not as good. Let's just say, like, for example, with vestibular migraine, the SSRIs, right? They can help, especially if there's a lot of triple PD. But SSRIs in general, for migraine, not as strong evidence for them. Yeah. So, those I tend to keep a little bit, lower on the list. But the rest of them, all of them could potentially work. The CGRP inhibitors that you brought up, those can work too. Issue is, you have to wait. Right, it can take up to 6 months for you to see benefit from them, and I always tell the patients, don't give up. Once you started it, you have to wait. Just give it about 6 months, before we judge whether it's working or not. It doesn't work. From what I've seen, there's no studies in vestibular migraine yet with the CGRP inhibitors, but with migraine themselves, it works very similar to, from what I've seen, the other migraine treatments too. So it's not to say that one is superior compared to the other.
Yeah, and you brought up another good point, and that's persistence in trialing these treatments. Can we go back to the devices, though? Can you explain a little bit to our audience how these work or what they do?
So the Cephally device, it stimulates the trigeminal nerve. So it's the ophthalmic branch of the trigeminal, the one that travels in the forehead, that's responsible for headache and sensation over the brain itself. We think that it could potentially help with people who have vestibular migraine and dizziness because, the trigeminal nerve is intimately connected with your vestibular nerve. That's part of the pathway is, telling your vestibular system what your eyes are doing. So if you move your eyes a certain way, that's how your vestibular system interacts with the eyes. Interesting studies have shown that trigeminal stimulation can alter nystagmus. Right? So, people who have congenital nystagmus, if you stimulate the trigeminal system, you actually can alter their nystagmus. And then there was a study that I think in migraine patients, noxious trigeminal stimulation also can alter or cause nystagmus in these patients. So there is a connection between the two systems. The Cephally device, I believe, taps into that connection. Another way that it can potentially, help theoretically, right, is, that it's been shown that the Cephally device can alter, I think, activity within the anterior cingulate cortex. And that is the area of the brain that is, very active, I think, in triple PD, right? Where, you become like very, vigilant about many of the symptoms, become hyper aware of, certain visual stimuli, certain things that make you dizzy. So that could potentially be the effect from the Cephally device. The gamma core works very differently. So the gamma core, it's a vagus nerve stimulator. So it goes on the neck, stimulates the cutaneous, through the skin rather, cutaneously. It stimulates the vagus nerve as it travels from your gut up to the brainstem. The vagus nerve is an interesting one. There's lots of connections with the trigeminal system, the vestibular system. That's why, when you get vertigo, you vomit. You feel really sick. Some people get diarrhea. They get really sweaty with it. It's all the vagus nerves connection. So vagus stimulation, I think, works predominantly through that. So it goes to the vestibular system directly and to the trigeminal system. The Cephally device goes through the trigeminal system, I think, to the vestibular system.
And that's using like almost like electrical stimulation, like a TENS unit type of a thing, right? So I know the gamma core goes over the neck, Cephally is over the head, and then the other device is back in the occipital region, right?
The gamma core, I don't think it's a TENS. I forget exactly, all the details about it, like how it stimulates and all that. But the Cephally is a TENS. That one is a TENS unit that goes on the forehead. And then I think the Relivion, if I remember correctly, the one that goes in the front and back is, I think it's also a TENS. I could be wrong, but I think it's also a TENS device.
Very cool.
Yeah, very cool stuff. So at what point are you suggesting that a patient would trial one of these?
Depending on their preference. So, if a patient has, like, say, if they want to try from the get-go, I'm open to that. These devices are really safe. Absolutely, you can start off with the devices. Yeah. Or, later on, if they've tried a number of medications and they've had a lot of side effects to the medications and they say, hey, you're done with medications, you want to try the devices? I say, go for it.
Can I change gears a little bit? I want to go back to testing. I kind of want to know what you look for in testing. Is there anything that you pick up on migraine patients that would be abnormal in VNGs or anything else that might pop up that you might order?
You can get some forms of nystagmus, for sure. Definitely you can get some unusual types of nystagmus. Sometimes it's not very specific types of nystagmus, like, can get a little bit of a positional nystagmus. That, from what I remember correctly, if I remember correctly, hyperventilation-induced nystagmus, the positional nystagmus, nystagmus with head shaking, those I tend to see quite a bit with people with vestibular migraine. Even if you examine them, in the interictal phase, not during an attack, you can see some nystagmus. Most of the time they won't even complain about dizziness or vertigo. You just lay them back, see the nystagmus, put them on the goggles to see the nystagmus. But so that's, not too specific. I've seen people who have upbeat nystagmus, I have some downbeat nystagmus, some very non-specific, geotropic or apogeotropic type of nystagmus. Sometimes you see nystagmus only in one position and not in another position, which, not too specific. There have been a few that, you do see the nystagmus when they're upright, and then, you move your finger around and, there's nystagmus going on there. So usually in those cases, I take a closer look at them and say, make sure we get the MRI, make sure, we have certain labs done, let's just say if it's downbeat nystagmus, then, I make sure that, all the causes of, cerebellar stuff we look into.
That makes me feel a whole lot better because since I've been practicing and using goggles, I have noticed that in my migraine or suspected migraine patients, you can elicit this weird nystagmus. It's something that you can identify in certain tests if you're looking for something specifically, but it can change throughout the evaluation. It might change from visit to visit. I see a ton.
Does anyone else see it changing? I'm like, hold on, did I not see this right the last time?
I'll see upbeat, usually a lot of upbeat nystagmus. I have one patient, and I know she wouldn't be upset if I shared her story, but her nystagmus was so almost dead on of looking like BPPV. It was misdiagnosed for the longest time. She would only get this torsional upbeat nystagmus in like a Dix Hallpike on one side, but then it would reverse if we got her onto her opposite side. So it would kind of go, and she was a little vertiginous, and we had all these other issues, but her history was screaming migraine. And it wasn't until we started with the BPPV as recommended by her referring doctor. But after a couple of months, we were like, I really think this is not right. We should really attack the migraine aspect of things. And once we went that direction, she started feeling better. But I think that it's worth it to mention this to people who are maybe just practicing or just getting into vestibular therapy and evaluation using infrared goggles, is you will find a really complicated eval. Don't overcomplicate a potentially simple situation. I'll have people say, it's definitely BPPV, but it's a posterior canal cupulolithiasis, or they'll make it some really crazy thing to explain the type of nystagmus they're seeing during testing, when really it could just be migraine activity, which is nuts.
That's true. There was I did a write-up, I think, on one of the patients. So in between exams, she would have, I think, geotropic nystagmus when you did the supine roll test, but no vertigo, no dizziness. Then during her migraine attack, it would reverse direction.
Oh, wow.
When you examined her, you did the same test. So I was lucky enough that I managed to catch her like twice during a migraine attack. It's very unusual. But, the thing is, the nystagmus would persist as long as you kept the head in the position. And she would have vertigo too. You turn the head to the right, to the left, she tells you it's spinning, and then you see the nystagmus going. And then, between exams, between attacks, it will reverse the direction completely. Now, I think you guys, you guys are the ones that pick it up all the time. The vestibular therapist was the one who said, this is not BPPV. And then, you need to see a neurologist.
Yeah, that's pretty wild. But not to complicate things further, but you can also indeed have vestibular migraine and BPPV.
Absolutely.
So
what are some
tricky?
What are some other layering conditions?
Some dogs have tics. Some
What are some other layering diagnoses that you see with migraine? Because I know migraine and Meniere's go hand in hand sometimes. Migraine and 3PD, migraine and BPPV. Like, is there one that's more common than the other? Like, what do you see a lot of combos of?
A lot of so BPPV is definitely there. Triple PD is there. Motion sickness is there as well. You can MDDS, another one that's quite a lot of people with MDDS also have a history of migraine or have a current diagnosis of migraine. Other ones like say Meniere's disease, we talk about that quite a bit. It's not as common, or maybe we're just under recognizing it. Not as common, as the other ones. You can have migraine, the headache type of migraine with vestibular migraine too. So I do have a group of patients who have both. They have bad attacks with the headaches, and then they have attacks with vertigo. And I think that's pretty much it off the top of my head. I can't think of any other vestibular diagnoses. Chiari, sometimes you tend to pick that up, Chiari malformation, but a lot of times it's an incidental finding.
Do you think people who are migraine patients or more prone to migraines are more likely to develop something like MDDS, which is maldated Markman syndrome, we should say?
Correct. Yep. So yes, definitely. The incidence of migraine among people with MDDS is definitely much higher than that of the general population.
Okay. Interesting.
Yeah. When I worked in clinic, we sometimes as vestibular therapists are sort of a dumping ground for anyone with dizziness. And I was curious, in your background with MS, if someone did complain of dizziness, what was your approach to trying to manage that?
So same thing, figure out what is causing the dizziness first. And I was doing this, I think I have about close to 80 patients who have MS and who came to me with dizziness and vertigo. The most common diagnosis, vestibular migraine and triple PD, and then BPPV. I'm like, okay. Only in a few of them that you can actually draw a link between the MS and the attacks of vertigo. So like they have like brainstem plaque, for example. You can see it there. Oh, okay, you have a brainstem plaque, and the description of the attacks, are not really consistent with that or migraine or anything. Then you're like, that's the one.
You kind of hit it right on the head. But I was gonna say, is it a lot less common to see MS with just a presentation of dizziness? We kind of are told to screen for it, and one of the things we look for is just a pure torsional nystagmus as being a feature that is pretty common to patients with MS. Is that correct? But not something I've ever seen in isolated situation since I've been practicing.
I think it varies so much. It depends on because MS can hit anywhere in the brainstem, right? So it depends on where it hits. The type of nystagmus that you get. Well, sometimes if you hit at the MLF, then you get internuclear ophthalmoplegia. If you hit the middle cerebellar peduncle or the superior cerebellar peduncle, you get one type of nystagmus. If you hit in the pons, you get one. Midbrain, you get different nystagmus. Medulla, you get a different type of nystagmus. So it depends where the lesions are.
That's a good point.
Yeah. So interesting, though. I mean, just the puzzle pieces that you have to put together to figure out what intervention to take. And along those lines, if you think about what diagnoses you're figuring out for a patient, who are you typically referring to vestibular therapy and who are you holding off on?
So if you talk about just vestibular migraine, then most patients, when I first see them, they are too dizzy to go for vestibular therapy. I learned that early on. So I was sending people to vestibular therapy early on, and one of the patients told me, after vestibular therapy, they had to just sit in their car and cry before they can drive home. I was like, oh, better hold back then.
We are mean.
But I tell the patients, if it's vestibular, the exercises are not at least uncomfortable, it's too easy for you. So I tend to hold off now a little bit until, if they are really, the hot migraine brain is just too excitable, then I get you on the right medication first. Let's calm things down a little bit. and we'll see how you do. If you still have, this head motion induced type of dizziness, very sensitive to like visual stimuli, then yeah, I'll send you off to vestibular therapy, get some things done. Triple, from the get-go, we can send people for vestibular therapy with starting the medications, or if they prefer just to do vestibular therapy, no medications, we can do that. MDDS, I think, is a trickier one. Y'all can tell me more, but I found from what I've seen so far, just regular MDDS, motion-triggered MDDS, no history of vestibular migraine, or no features of like triple PD going with it. I found that they're not as responsive to vestibular therapy. What have you all found?
No, this is much more difficult to treat. And the research in it, there's more that came out recently. I know Dr. Dai up in New York did a lot of work on that and came up with a very specific protocol. I remember being at the research conference up in Mount Sinai, I think back in 2019 it was. They explained the protocol and it made my own head spin. I'm like, this would be very hard to replicate in the clinic. I don't think that this is something that I'd be able to do. And this is why they have their program where people with MDDS go up there for 2 weeks to undergo treatment. We approach it like a triple PD with people that have this increased motion sensitivity. And we kind of work on habituation, adaptation. But again, it's very difficult to kind of get those patients to respond like we'd like them to. So it's definitely not an easy diagnosis.
I think it more often than not, though, if they are seeing us, it's not just MDDS. It is, like you said, MDDS, 3PD, that type of situation. And we've talked about this too, but sometimes just educating patients can go a long way. If they don't understand what's happening, why it's happening, how it started, etc. Sometimes just sitting down with them and explaining to them their vestibular system, the impact it has on their everyday life, why we do the exercises we do. What's a good sign if you respond this way to an exercise? Do we think that this is the route we need to go? It's sometimes relieving just talking to someone. And I've actually gotten that feedback from some patients that I've sent to you. They were so relieved that you spoke to them, you had a conversation with them, you took a good history with them, that they immediately felt comfortable in your care.
Yep. The illness uncertainty, I think that one, plays a big role in a lot of chronic diseases, especially. Yep. And, particularly like dizziness, vertigo, they bounce from person to person. No one can really explain the symptoms to them. They just get called vertigo. And, I think having a diagnosis, something to focus your energy on, something to read up about, I think that also takes a lot of the uncertainty and anxiety away from things.
Well, I think one of the biggest pieces of education that has come out recently is your book. Once again, what led you to write this? It is the most comprehensive workup of everything migraine, vestibular migraine, A to Z, medications, devices, like how to go into your doctor's appointment. Everything. When did you start writing this, and what led you to do this?
So I think the idea came from, I had to write a review for the Journal of Neuro-Ophthalmology about vestibular migraine. That got me started to think when I was writing the review, I was like, you know what, rather than just putting this and say on PubMed, you have to have a subscription to something, and only, professionals can read it. I thought, patients would benefit from this quite a bit. There's so much to teach them and so little time that we have in clinic, and when you see them, you can only, spend so much time with them, right? And so actually I began writing at the beginning of the pandemic. I was like,
how did you get that done?
I was like, couldn't go anywhere, couldn't do anything. So, just at home, like,
I've been writing a book for about 10 years now. I'm shocked. I'm so impressed.
At the beginning of the pandemic, I was like, I have to do something. I'm not going to go crazy if I just sit around and do nothing. To finish everything on Netflix already. All right, time to do some work. And so, I took the stuff from the review, and I was like, we can expand a lot on it. And so, started that process.
Oh, it's amazing. It's definitely one of the things I recommend to patients. I usually dip their toes in with the, it's more than a migraine article by Dr. Teixeira and Dr. John Carey. And then I said, but listen, this is just a little tease. What you really want to get is Dr. Beh's book, Victory Over Migraine. Because again, A to Z, I have so many patients who are very type A about what this migraine journey is going to look like, and they want to know everything. And I'm grateful for it because they come into me and they're like, what about this gamma core thing? I'm like, the what? I don't know. I'll look into it and I'll get back to you. So something like this has been essential for me as a clinician. So I recommend to our listeners, if you're a clinician, if you're a patient, it definitely needs to be checked out. It's on Amazon. We'll link it in the show notes. It's been a lifesaver, and congrats on this book. This is amazing. I have this. I have Alicia's cookbook in my office. I have everything on hand because it's just been so helpful with my migraine patients.
It truly is. It really is. And those same type A patients will come back to you and say, oh, I finished the book. And it was like 2 days. They just sat with it all weekend, it seems, because it was so good for them, especially because when you write something like that, it's relatable. They're like, oh my gosh, someone actually understands. And I think that's a key piece too in the care that we provide is just the empathy part of it, Do you have any other upcoming research that you're working on?
So, not so much, unfortunately, because I am moving into private practice. So,
very nice.
That has been taking a lot of time, trying to navigate the whole process, getting credentialed by insurance, getting location and everything. That is eating up a lot of time, but thank goodness, more or less settled now. So,
I know how that goes.
So, that one, coming soon. So, by August, I'll be out of UT in my own practice. I'll still be in Texas. Yep. And it's focusing on, vertigo and migraine.
Well, be sure to forward that.
Yep, Frisco. So just a little north of Dallas. Yep.
Okay. And maybe just to kind of round out our episode, could you just give us a little brief overview of what people should bring to maybe their first appointment, if they should prepare a certain thing or what they should kind of get themselves ready for going into an appointment for vestibular migraine or somebody like you or you yourself?
Yeah. Any time you come with vertigo or dizziness, I think the first thing I want to understand, and I want to hear patients describe to me, what are you feeling? What do you mean by dizzy? What do you mean by vertigo? I think because they've seen, many of them, like in your experience, I'm sure, they've seen many different people and they get the labels, dizzy or vertigo, and they start to just use them. Sometimes it's incorrectly used, or sometimes, they have more than one symptom and you have to really figure out what's going on. A good example is, if you have, say, vestibular migraine and BPPV, right? The mistake that's a lot of times will happen is everything gets lumped together. But then, once you start drilling down and you're like, okay, with the vestibular migraine, then, I get this tilting, rocking type of feeling, lasts for a whole day, light sensitive, sound sensitive. And then from time to time, I get this awakened by this spinning that happens, wakes me up from sleep, lasts for a few seconds and then goes away. So, then you're like, okay, you have this. Or the thing that makes it complicated is if they have, like, say, MDDS and vestibular migraine. I've seen quite a large number of patients with that recently. And so, they tell you that they have this constant feeling as if they're on a boat, moving around. It's better when they are in a moving car. But on top of that, they also have these episodes where, the rocking gets much more intense. And then some develop, additional stuff, spinning, feeling as if they're falling with the migraine symptoms. And they're like, okay, so you do have, MDDS and you have vestibular migraine. So I think being able to describe the symptoms, is very important. And then, of course, come with your medical records. If you have had like MRIs done, VNGs done, hearing tests done, bring them along.
Do you ever recommend patients bring in like a food or a symptom log, like how long the symptoms should last, or if they notice that they get any symptoms after eating? Does that help, or does that not matter so much?
I think the food log can be a bit confusing at times. So, usually I tell my patients, look at, try to see if there's a pattern. So if you eat something and you consistently get, your migraine attack after eating it, that's most likely your food trigger. But, if you just feel a little bit dizzy, a little off, probably not a food trigger. And it can be a little tricky to identify, I think, especially let's say if you have, celiac disease, gluten sensitivity, lactose intolerance. On top of that, then, things start to meld together. And so, I think it takes a little, rather than, every single food and you try to figure out what symptom that you have after eating, I think, a general pattern as to, if you eat this, consistently, if I eat, sausages, I get a migraine attack. The processed meats probably do it for you. If you eat the smelly cheese, you consistently get an attack after eating smelly cheese.
That's a good point.
Yeah, very good point. Dr. Beh, you are such a knowledgeable man. I thank you so much for coming on the show. And actually, if you want to hear more of his knowledge, he is on Twitter. What is your handle on Twitter?
At Dizzy Doc.
At Dizzy Doc. I mean, it makes sense. Perfect name.
No.
Thank you again for coming on the show.
Thank you so much for having me. Yep.
If you're interested in finding us on social media or the web, you can visit www.vestibular.today for more resources, including testing, treatment, and educational videos, blogs, continuing education classes, and resources including clinic equipment recommendations, suggested tests, and BPPV treatment charts.
Search Vestibular Today and Balancing Act Rehab on all social media platforms, including Facebook, Instagram, Twitter, and YouTube. Also, be sure to check out Balancing Act Rehab at www.balancingactrehab.com, especially if you think you would benefit from vestibular therapy. We are your girls. The information on this podcast is not intended to replace the care provided by your qualified health professional or to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding a medical condition. Never disregard professional medical advice or delay in seeking it because of something you have heard on Talk Dizzy to Me. Please contact us at Balancing Act Rehab if you think you could benefit from vestibular therapy.